Good day, learners. This is Mrs. Marichel Valerie Peel Marioles, and I will be your facilitator for Module 2M, or the care of clients with drugs affecting the central and peripheral nervous system. I hope you have watched the video on the review of the anatomy and physiology of the central and peripheral nervous system. Before we start our class or lecture, let us now recapitulate very important aspects regarding the nervous system. The nervous system is composed of all nerve tissues, including the brain, the spinal cord, the nerves, and the ganglia. Remember that the nervous system receives stimuli and transmits information to nerve centers for an appropriate response. And that the nervous system has two types, which are the central nervous system and the peripheral nervous system, which are abbreviated as CNS and PNS accordingly. Now let's start with the central nervous system. The central nervous system is composed of brain and spinal cord. It regulates body functions. It also interprets information sent by impulses from the peripheral nervous system and returns the instruction through the peripheral nervous system for appropriate cellular action. Stimulation of the central nervous system may either increase the neuron activity or block the nerve cell activity. The peripheral nervous system, on the other hand, consists of two divisions: the somatic nervous system, or the SNS, and the autonomic nervous system, or the ANS. The somatic nervous system is voluntary, and this is responsible for locomotion and respiration. When we say voluntary, that means that a person can control it. Let's say locomotion, that can be controlled by a person, as well as respiration. In contrast to the somatic nervous system, the autonomic nervous system is involuntary in nature. This system is responsible for the functioning of the heart, respiratory system, the gastrointestinal system, and the glands. And when we say involuntary, that means that it cannot be controlled by the person. The first group of medications we will discuss are the stimulants. Numerous drugs can stimulate the central nervous system, which involves the brain and spinal cord and regulates body functions. Medically approved use of CNS stimulants is limited to the treatment of attention deficit hyperactivity disorder in children, or ADHD, narcolepsy, and the reversal of respiratory distress. Now let's talk about the attention deficit hyperactivity disorder, or ADHD, first. This is also called as minimal brain dysfunction hyperactivity in children, hyperkinesis, and hyperkinetic syndrome with learning disorder. This might be caused by dysregulation of the transmitters serotonin, norepinephrine, and dopamine. This may occur before 7 years of age and may continue through teenage years. This is evident 7 times more in boys than in girls. This is characterized by inattentiveness, inability to concentrate, restlessness or fidgety, hyperactivity or excessive and purposeless activity, inability to complete tasks, and impulsivity. Another indication for stimulant is narcolepsy, which is characterized by falling asleep during normal waking activities such as driving a car or talking with someone. Can you imagine that? You are driving a car or you're just talking to someone and suddenly you fall asleep? What possible nursing diagnosis can you formulate with this one? If you're talking about risk for injury, that is correct. Narcolepsy is usually accompanied with sleep paralysis, which affects the voluntary muscles, in which the person will be unable to move and may collapse. Another indication for stimulant is the respiratory distress, which refers to a condition in which the person is having trouble breathing, which often show signs that they are having to work harder to breathe or are not getting enough oxygen. This condition prevents the body organs from getting the oxygen they need to function. These are the major groups of stimulants that we will also cover in this lecture. First, we have the amphetamines and caffeine. The amphetamines and caffeine will stimulate the cerebral cortex of the brain. Another stimulant would be your anorexins. These anorexins suppress appetite by stimulating the satiety center of the hypothalamic and limbic areas of the brain. The third one would be the analeptics and caffeine, which act on the brainstem and medulla to stimulate the respiration. Now let's discuss the first stimulant, the amphetamines. Examples of amphetamines are amphetamine sulfate, dextroamphetamine sulfate, and lisdexamfetamine dimesylate. These medications stimulate the release of norepinephrine and dopamine from the brain and the sympathetic nervous system and inhibit the reuptake of these transmitters. Amphetamines ordinarily cause euphoria and increase alertness as well as insomnia, restlessness, tremors, irritability, and weight loss. Increased heart rate, palpitations, cardiac dysrhythmia, and increased blood pressure can also result from cardiac stimulation and vasoconstriction with continuous use of amphetamines. Take note that excessive use may lead to psychosis. Amphetamines have a half-life of 9 to 13 hours. Amphetamine and dextroamphetamine are prescribed for narcolepsy and ADHD when amphetamine-like drugs are ineffective. Further, amphetamine and amphetamine-like drugs should not be administered in the evening or before bedtime because insomnia may result. So what is the nursing implication for this one? It is best to administer amphetamines in the morning so as not to interfere the sleep of the patient. These are the side effects and adverse reactions of amphetamines. So we have here dizziness, headache, euphoria, confusion, blurred vision, restlessness, insomnia, tachycardia, hypertension, dysrhythmia, dry mouth, anorexia, weight loss, diarrhea, constipation, seizure, tremors, and erectile dysfunction. Take note that you may formulate a nursing diagnosis based on the side effects and adverse reactions of the medication. Take for example, for seizure, you may formulate risks for injury related to adverse reaction of the medication or adverse reaction of amphetamine. There are also medications called amphetamine-like drugs. Examples of these medications include methylphenidate hydrochloride, modafinil, dexmethylphenidate hydrochloride, and armodafinil. These medications are used for ADHD and narcolepsy. These are effective in treating ADHD than amphetamines. Methylphenidate and dexmethylphenidate are given to increase a child's attention span and cognitive performance and to decrease impulsiveness, hyperactivity, and restlessness. Methylphenidate is most frequently prescribed drug in the treatment of ADHD. Modafinil increases wakefulness in patients with sleep disorders such as narcolepsy. Amphetamine-like drugs are classified as Controlled Substance Schedule or CSS2 drugs, meaning that this medication cannot be purchased using ordinary prescriptions, and the physician who can only prescribe these medications are only the physicians who have CSS2 licenses as well. This medication is well absorbed from the GI mucosa. This is usually administered to children twice a day before breakfast and lunch. Take note that food affects absorption rate. Thus, It has to be given 30 to 45 minutes before meals. And it should be given at least 6 hours before sleep because it can cause insomnia. Transdermal form of medications may be worn for 9 hours. When methylphenidate is combined with sympathomimetics like pseudoephedrine or with psychostimulants like caffeine, it will result to irritability, nervousness, tremors, and insomnia. When methylphenidate is combined with monoamine oxidase inhibitors or MAOIs, it will result to hypertensive crisis. Further, methylphenidate potentiates the action of the CNS stimulants like caffeine. It also inhibits the metabolism of some barbiturates, example, phenobarbital. Side effects of methylphenidate hydrochloride include the following: anorexia, dry mouth, nausea, vomiting, dizziness, insomnia, irritability, tremors, euphoria, blurred vision, headache, abdominal pain, and anemia. Adverse reactions of the medication will include tachycardia, hypertension, growth suppression, palpitations, seizure, transient weight loss in children, exfoliative dermatitis, stroke, thrombocytopenia, and hepatotoxicity. Now let us apply nursing process in the care of clients who are taking methylphenidate hydrochloride. In the assessment, you need to determine whether the patient has a history of heart disease, hypertension, hyperthyroidism, Parkinsonism, or glaucoma. In such cases, this drug is usually contraindicated. You should also assess vital signs to be used for further comparisons. Closely monitor patient with cardiac disease because this drug may cause tachycardia, hypertension, and stroke. You must assess patient's mental status such as mood, affect, and aggressiveness. You must also evaluate the height, weight, and growth of children. Assess also complete blood count or CBC, differential white blood count or WBCs, and platelets before and during drug therapy. As for the nursing diagnosis, here are samples. We have risk for health behavior that interfere with peer relationships, interrupted family process related to dysfunctional behavior. So what is our plan? What is our objective in administering methylphenidate hydrochloride? That is to decrease the patient's hyperactivity or increase the patient's attention span. So basically, this is related to ADHD. As for the nursing interventions, we need to monitor vital signs and report irregularities. We also need to evaluate the height, the weight, and the growth of children, especially that one of the adverse effects of methylphenidate hydrochloride is growth suppression. We also need to observe for withdrawal symptoms and side effects. Teach patients to take the drug before meals. Advise patients to avoid alcohol consumption. Encourage use of sugarless gum to relieve dry mouth. Teach patients to monitor weight twice a week and report weight loss. Advise patients to avoid driving and using hazardous equipment when experiencing tremors, nervousness, or increased heart rate. Teach patients not to abruptly discontinue the drug. The dose must be tapered to avoid withdrawal symptoms. Consult a healthcare provider before modifying doses. Encourage patients to read labels on over-the-counter products because they contain caffeine. A high plasma caffeine level could be fatal. Teach nursing mothers to avoid taking all CNS stimulants. These drugs are excreted in breast milk and can cause hyperactivity or restlessness in infants. Direct families to seek counseling for children with ADHD. Drug therapy alone is not an appropriate therapy program. Notify school nurse of drug therapy regimen. Explain to patients and family that long-term use may lead to drug abuse. Advise patients to avoid foods that contain caffeine, like coffee, tea, chocolates, soft drinks, and energy drinks. Encourage parents to provide children with a nutritious breakfast because a drug may have anorexic effects. Teach patients about drug side effects and the need to report tachycardia and palpitations. Monitor children for onset of Tourette syndrome. When we say Tourette syndrome, this refers to a neurological disorder characterized by repetitive, stereotyped, involuntary movements and vocalizations called tics. So this is usually in children. As for the evaluation, we need to evaluate the effectiveness of drug therapy, the level of hyperactivity, and presence of adverse effects. We also need to monitor weight, sleep pattern, and the mental status for any changes. Another amphetamine-like drug is modafinil. This one is used to increase wakefulness in patients with sleep disorders such as narcolepsy. This time, we are going to tackle the second stimulant called anorexins. Examples of anorexins include bensphetamine, diethylpropion hydrochloride, phentermine hydrochloride, phentermine topiramate, phendimetrazine, liraglutide, naltrexone hydrochloride, and bupropion hydrochloride. These medications cause a stimulant effect on the hypothalamic and limbic regions of the brain to suppress appetite. These medications do not have serious side effects associated with amphetamines. Reliance on appetite suppressants should be discouraged. Children younger than 12 years old should not be given with this medication. Long-term use of this medication results to nervousness, restlessness, irritability, insomnia, palpitation, and hypertension. Now let's proceed to the third stimulant, which is called analeptics. Examples of analeptics are caffeine citrate, theophylline, and doxaprom. These types of medications are used to stimulate respiration. One subgroup of analeptics are the xanthines, or the methylxanthines, of which caffeine and theophylline are the main drugs. Caffeine stimulates the CNS, and take note, large doses of caffeine will stimulate respiration. Theophylline, on the other hand, is mostly used to relax the bronchioles and used to increase respiration in newborn. You will also encounter theophylline when you are already in your respiratory system discussion. Side effects of analeptics will include the following: nervousness, restlessness, tremors, twitching, palpitation, insomnia, diuresis, GI irritation, and tinnitus. But tinnitus is very rare. Take note that excessive caffeine can affect both the CNS and the heart, of which may result to convulsion and dysrhythmia accordingly. Okay, so to recap, we have discussed or we have tackled stimulants. So under stimulants, we have here amphetamine and amphetamine-like drugs. So take note, these types of medications are used for narcolepsy and ADHD. We also tackled anorexins, of which are used to suppress appetite. And lastly, the analeptics, which are used to stimulate respiration. Okay, so I hope you will remember this one. Now let's move on. Drugs that are central nervous system depressants cause varying degree of depression or reduction in the functional activity within the central nervous system. The degree of depression depends primarily on the drug and the amount of drug taken. The broad classification of CNS depressants include sedative hypnotics, general anesthetics, analgesics, opioid and non-opioid analgesics, anticonvulsant, antipsychotic, and antidepressants. Among these classifications of depressants, we are going to focus on the sedative hypnotics. Before we resort to pharmacologic treatment, we need to try first non-pharmacologic ways to promote sleep. Why are we talking about sleep? Because we are talking about sedative hypnotics in order to promote sleep to person. So, why should we try non-pharmacologic ways first? This is to make sure that we will avoid drug dependence as well as drug tolerance. So what are non-pharmacologic ways to promote sleep? We need to arise at a specific hour in the morning. Take few or no daytime naps. Avoid drinks that contain caffeine and alcohol 6 hours before bedtime. Avoid heavy meals or strenuous exercise before bedtime. It's also encouraged to take a warm bath, listen to quiet music, or perform or soothing activities before bedtime. Decrease exposure to loud noises. Avoid drinking copious amount of fluids before sleep, and to drink warm milk before bedtime. Sedative hypnotics, again, are commonly ordered for sleep disorders. Examples of sedative hypnotics include secobarbital sodium, butabarbital sodium, phenobarbital, pentobarbital, and mephobarbital. Sedation is the mildest form of CNS depression. And take note, hypnotic effect is a form of natural sleep. Hypnotic drug therapy should be short-term. This is to prevent drug dependence and drug tolerance. Interrupting hypnotic therapy can decrease drug tolerance, but abruptly discontinuing a high dose of hypnotic taken over a long period can cause withdrawal symptoms. So what is the nursing implication for this one? The medication must be tapered. When you say that the medication must be tapered, the medication should not be stopped abruptly. In other words, if one person is taking, let's say, 500 milligrams of the medication, the patient should not abruptly discontinue the medication. Instead, the medication will be reduced gradually until the medication will not be taken anymore by the patient. The general rule for sedative hypnotic therapy is that the lowest dose should be taken to achieve sleep, and patients with severe respiratory disorders should avoid hypnotics, which could cause an increase in respiratory depression. Take note that hypnotics are contraindicated during pregnancy, and Ramelteon is the only major sedative hypnotic approved for long-term use. Because take note, we mentioned earlier that sedative hypnotics should be used for short-term only. And again, Ramelteon is the only major sedative hypnotic approved for long-term use. This drug may be used to treat chronic insomnia. The first type of sedative hypnotic we will discuss are barbiturates. These medications are useful as sleep sustainers for maintaining long periods of sleep. Classifications of barbiturates include long-acting, intermediate-acting, and short-acting. Under long-acting, we have phenobarbital and mephobarbital. Butabarbital is classified as intermediate-acting, and secobarbital is classified as short-acting. Barbiturates should be restricted to short-term use like 2 weeks or less. This is because of their numerous side effects. Pentobarbital and secobarbital are used primarily to treat insomnia. The onset of action of pentobarbital is slower when administered IM than when administered PO. Again, students, please take note of this one because this is quite unusual. The onset of action of pentobarbital is slower when administered IM than when administered PO. Whereas for pentobarbital, this medication increases hepatic enzyme action, causing an increased metabolism and decreased effect of drugs such as anticoagulants, glucocorticoids, tricyclic antidepressants, and quinidine. Pentobarbital may cause hepatotoxicity if taken with large doses of acetaminophen. Do not confuse phenobarbital and pentobarbital. Side effects of barbiturates include the following: hangover, rapid eye movement rebound, dependence, tolerance, excessive CNS depression, respiratory depression, and hypersensitivity. Another sedative hypnotics that we will tackle are benzodiazepines. Benzodiazepines are used to induce sleeping. These medications increase the action of the gamma-aminobutyric acid or GABA to the GABA receptors, which in turn will reduce the neuron excitability. Examples of these medications are alprazolam, esdazolam, lorazepam, temazepam, triazolam, quazepam, diazepam. And take note when these medications are taken with an overdosage or with an increased dosage. Take note of the antagonist flumazenil, meaning that this is the antidote for overdosage of these medications. One of the reasons why people can't sleep well is because of increased anxiety. So again, let me reiterate that. Increased anxiety can be the cause of insomnia for some patients. And so, the medications lorazepam and diazepam can be used to alleviate the anxiety so that the person can have a better sleep. Benzodiazepines are effective for sleep disorders for several weeks longer than other sedative hypnotics. To prevent rapid eye movement rebound, they should not be used for longer than 3 to 4 weeks. The adverse reaction of this medication is anterograde amnesia, which refers to the impaired ability to recall events after dosing. Associated with anterograde amnesia are sleep-related behaviors such as preparing and eating meals, sleep driving, engaging in sex, or making phone calls during sleep without any memory of the event. Alcohol and CNS depressants increase the risk of sleep-related behaviors. Side effects associated to alprazolam usage include lethargy, drowsiness, dizziness, headache, constipation, and anterograde amnesia, and so on and so forth. Adverse reactions for alprazolam include depression, tolerance, dependence, withdrawal, hypotension, tachycardia, and seizure. Now, let us apply the nursing process when administering benzodiazepines to our patients. Under assessment, we need to obtain a drug history of current drugs and complementary and alternative therapies that a patient is taking, especially CNS depressants, which would potentiate respiratory depression and hypotensive effects. Also, we need to assess baseline vital signs for future comparisons. We need to determine whether the patient has a history of insomnia or anxiety disorder. Another is, we need to assess renal function. Urine output should be 1,500 ml per day. Renal impairment could prolong drug action by increasing the half-life of the drug. So what are the nursing diagnoses that we can formulate out of this medication administration? We could formulate sleep deprivation related to adverse effect of insomnia. Another example is ineffective breathing pattern related to CNS depression. Now, I would just like to emphasize that these nursing diagnoses presented are just two parts. We only have the problem statement or the diagnostic statement as well as the etiology. There's no specific sign presented here. Let us determine our plan or our objective of administering benzodiazepines to our patient. That is for our patients to receive adequate sleep when taking benzodiazepine. What particular nursing interventions should we incorporate or should we perform for patients who are taking benzodiazepine? The following: monitor vital signs, especially respirations and blood pressure, must be performed by the nurse. Another is, the nurse must encourage the patient to use bed alarm, especially for adults and for patients receiving a hypnotic for the first time. Confusion can occur and injury could result. Observe the patient for adverse reactions, especially an older adult or a debilitated patient. Examine the patient's skin for rashes, as skin eruptions may occur in patients taking benzodiazepines. Patient teaching for patients taking benzodiazepine will include: avoid alcohol, antidepressants, antipsychotic, and opioid drugs while taking benzodiazepines. Respiratory depression can occur when these drugs are combined. Advise patient not to drive a motor vehicle or operate machinery when using benzodiazepines. Teach patient that benzodiazepines should be gradually withdrawn, or again, the medication has to be tapered. For the evaluation, we need to assess the effectiveness of benzodiazepine. So how do we do that? We need to assess whether the patient has achieved better sleep or not. Another, we also need to evaluate the respiratory status of the patient. Another sedative hypnotics that we will discuss are non-benzodiazepines. Why are they called non-benzodiazepines, by the way? Non-benzodiazepine pharmacodynamics are almost entirely the same as benzodiazepine drugs and therefore employ similar benefits, side effects, and risks. However, non-benzodiazepines have dissimilar or entirely different chemical structures and are therefore unrelated to benzodiazepines on a molecular level. Examples of non-benzodiazepines are zolpidem tartrate, exopiclone, and zaleplon. As for zolpidem, this is used for short-term treatment of insomnia. Specifically, it's less than 10 days. This medication has a half-life of 1.4 to 6.73 hours. This medication is metabolized in the liver and excreted in the bile, urine, and feces. Dose should be decreased if prescribed in adults. Side effects of the medication include drowsiness, lethargy, headache, hot flashes, hangover, and so on and so forth. As for the adverse reaction, it includes tolerance, psychological or physical dependence, withdrawal, and so on. When administering non-benzodiazepines to patients, we need to assess the following: vital signs and laboratory tests like aspartate aminotransferase, alanine aminotransferase, and bilirubin. In other words, we need to check for the liver function. We also need to obtain a drug history. As for the nursing diagnosis, we can formulate these. We have sleep deprivation related to anxiety. Another is fatigue related to insomnia. What is our plan, by the way? Why are we administering non-benzodiazepines to our patient? That is for the patient to remain asleep for 6 to 8 hours, or in other words, we want the patient to achieve a better sleep. As for the nursing interventions, we need to monitor vital signs, check for signs of respiratory depression like slow, irregular breathing patterns, use bed alarm for older adults or patients receiving non-benzodiazepines for the first time. Confusion may occur and injury may result. Observe patient for side effects of non-benzodiazepines such as hangover or residual sedation, lightheadedness, dizziness, or confusion. Patient teaching during non-benzodiazepine therapy will include the following. Teach patient to use non-pharmacologic methods to induce sleep, like taking a warm bath, listening to music, drinking warm fluids such as milk, and avoiding drinks with caffeine after dinner. Encourage patients to avoid alcohol, antidepressants, antipsychotics, and narcotic drugs while taking non-benzodiazepines. Severe respiratory depression may occur when these drugs are combined. Advise patients to take non-benzodiazepine before bedtime. Alprazolam takes effect within 15 to 30 minutes. Suggest that patients urinate before taking non-benzodiazepines to prevent sleep disruption. Encourage patients to check with a healthcare provider about over-the-counter sleeping aids. And warn the patients to use caution while driving as drowsiness may occur. Further, advise patients to report adverse reactions such as hangover to a healthcare provider. Drug selection or dosage may need to be changed if hangover occurs. For the evaluation, evaluate the effectiveness of sedative hypnotics in promoting sleep. So you need to assess the duration of sleep of the patient as well as the quality of the sleep of the patient. You also need to determine for development of side effects. Now let's move on to the fourth sedative hypnotic, which is the melatonin agonist. Ramiltion is the newest category of sedative hypnotics called melatonin agonists. Ramiltion is the first hypnotic approved by the US FDA that is not classified as a controlled substance. This drug acts by selectively targeting melatonin receptors to regulate circadian rhythm in the treatment of insomnia. Ramiltion has not been shown to decrease rapid eye movement sleep. This drug has a half-life of 1 to 2.6 hours. Adverse effects of the medications include drowsiness, dizziness, fatigue, headache, nausea, and suicidal ideation. Okay, so just a recap. So we mentioned earlier that under depressants, there are medications or classifications called sedative hypnotics, general anesthetics, analgesics, which can be opioid and non-opioid. We also have antipsychotic and anticonvulsants, as well as antidepressants. And among these, we have discussed sedative hypnotics. And under sedative hypnotics, we discussed barbiturates, benzodiazepines, non-benzodiazepines, and melatonin agonists. Do not forget that the sedative hypnotics that we have discussed are given to patients who have problems in sleeping. So again, these medications are used to promote better or quality sleep to the patients.